Good morning, good afternoon, good evening, and good night. Welcome everyone to this 18th series. Yes, it is 18th series of WSPOS webinar. And this is something special we are having today. This is the inaugural WSPOS Global Grand Rounds. So this is something different, what I've been doing till now. I want to welcome every one of you to this webinar. In this COVID time, social distancing is kind of on the rise. But for WSPOS and our global family, as you can see in these three graphs, the global membership from the last 6 months, it's increasing. YouTube at the beginning of April, it was 0. Now we have 2,500 members. And on the Facebook page, we have close to 3,700 members. So the virtual distance amongst us is decreasing, and your enthusiasm and energy and support in these webinars is very, very welcome. And thank you for all the support week after week. And in this difficult time, we are learning as well as sharing as a community. Thank you for that global family. A big namaste from India to all of you. I just want to take a few seconds to talk about our WSPOS WW Connect meeting of 2020, which is slated to be happening on 26th September. All of you are welcome to this. We have made a fantastic program having 14 sessions, including, in addition to that, industry session of 3 with different time zones. It's Australia, including all part of Asia, China, Hong Kong, and then it moves to Indian Standard Time, which is inclusive of Africa and Middle East. And then again, it comes to British Summer Time. Again, it's inclusive of the Middle East and Africa. And then finally, the US time, inclusive of North America as well as South America. So that way, we are moving across the globe. You will be able to attend. In addition, you can also attend WSPOS ESCRS Symposium on 2nd October. Additionally, 3 keynote lectures on 3rd October, as well as best of the best free papers and posters and videos. These are the registration details. It's available to all of you if you go to the WSPOS website. It's pretty much easy, and we have kept the registration fees very, very reasonable. Sometimes it can be just a visa fee to if you want to travel to any other country. That's where we have kept it nominal so that our friends around the world can join. And also, additionally, none of us have to travel, and we don't have to face that annoying the jet lag. We are at home, but we can travel around the world. That's what we have done for this meeting. I also encourage everyone to open this menti.com. This is the Mentimeter. If you can browse in your laptop or mobile phone. Passcode for today is easy, 205, 206. It's 205 and 206. And if someone of you want to take a quick response code, this is the code. You can take a picture of this. It directly goes to the Mentimeter. Today's is a global case report. The opinion about the audience as well as panelists matters. And we are going to make a PDF file of this as we used to do for the global case report. And we are going to share with every one of you. And we have different live stream today on Facebook, as usual, YouTube. If you have any questions, please write there. And as many questions we will try to answer today. If we can't, we will answer it later. And obviously, all of you will be getting the participation certificate. Please email to wspos@wspos.org. We will get back with the participation certificate. Coming to the introduction of today's speakers as well as panelists, the first presenter is Jamila Hiasat. She completed her ophthalmology residency from University of Jordan, Amman, Jordan. And she's currently doing a fellowship in pediatric ophthalmology and strabismus and adult mortality at Children's Hospital, Pittsburgh, USA. She's going to present two amazing cases today, and we will have fun in learning and sharing and your opinion, and we will have a different perspective. Both the cases are very, very interesting. Next on the panel, we have Dominic Bremont-Gignac. She is the head of the Department of Ophthalmology as well as the Pediatric Ophthalmology subspecialty at the University Hospital Necker. She is also in charge of Orthoptics Department at Paris V University. Her research interest is in the development of oculo-orbital structure, which is very, very interesting, and also ocular surface morphology. She has done a lot of work in these areas, and she has been a principal investigator for more than 10 clinical research studies, and she has contributed significantly as a non-executive director of WSPOS. Welcome, Dominic, for this webinar. Next, we have Nicolene Chalich-Delphos. She is a professor of pediatric ophthalmology at Leiden University Medical Center. Her special interests are in unique way. It's normal and abnormal vision development and systemic eye diseases. And she specialized in pediatric lens and complex strabismus surgery. And her research area is retinopathy of prematurity. She was the local host president for our WSPOS 5, and she'll be continuing, and she'll be contributing a lot to this webinar as well. Thank you so much, Nicolene, for joining today. And last, we have Kim Tan, our friend, and he's the director of our Global Case Report Bureau. He's been doing a fantastic job of publishing these PDFs of many, many cases till now. And he's also head of Department of Ophthalmology, Sydney Children's Hospital, Australia. And he's also a lead visionary in the pediatric ophthalmology, the program called Sight for All at Adelaide, Australia. And he's been the driving force of this global case reports. Today, we have converted into a webinar, and we are going to have more and more global GAN-downs. I expect a lot of submission from our members all around the world. Now I share the screen to Kim.
Thank you, Ramesh, and thank you for the kind words. Look, it's a very exciting time for the these global case reports. I think this is a fantastic initiative of WSPOS. It's been a wonderful experience to be involved in WSPOS. I think we all look forward to the Worldwide Connect as the next initiative. All my residents and fellows here and colleagues are really looking forward to it. All the people I work through Asia. So it'll be the next fantastic initiative. And responsible for these initiatives, besides yourself, of course, is the first introduction. David Granite, who needs no introduction. He's a co-founder of this WSPOS, a driving force with his innovation. He's the vice chair of the Vitaby Family Department of Ophthalmology at the Charlie Eye Institute. He's the system-wide chief of pediatric ophthalmology and Anne Ratner Professor of Ophthalmology. He obviously has an extremely lovely family too. David, one day when we can travel, it'll be lovely to meet them in person. Next slide. That's a nice photo of Ramesh. We all know Ramesh as well. Ramesh is very generous with his expertise and his teaching talents when we could travel and virtually. He mentioned the hard work of the Global Consult Bureau, but the person in the picture with Ramesh is the real workhorse who does all the hard work, Akila. Ramesh is the head of Child Sight Institute at Justiviar Ramana Children's Eye Care Centre at the LV Prasad Eye Institute at Hyderabad. He has many special interests, but they include complex strabismus, pediatric cataract, and pediatric neuro-ophthalmology. Thanks, Ramesh. I've also the pleasure of introducing one of our panelists, Saurabh Jain. He's one of the leading ophthalmologists in London. He's a consultant ophthalmologist and training program director of the London residency program. He's been well lauded by the trainees there, and he's a special interest in their development and strabismus. Thanks for joining, Saurabh. It's also a pleasure to introduce the real first speaker. Jamila is going second, Ramesh. Gura is going first. Gura Chatanava, and she's continuing her studies with a fellowship in strabismus, pediatric ophthalmology and neuro-ophthalmology at LV Prasad. With the busy work there, of course, she has an interest in infantile cataract, complex strabismus and neuro-ophthalmology. It's lovely to see she has other interests in painting and traveling and gardening as well. I'd also like to comment there's a steady stream of countries joining this worldwide webinar. It's truly across the entire planet. Indonesia, of course, the ones that we represent, the US, India, Russia, but also Singapore, Mexico, Zambia, Argentina, Spain, South Africa, Chile, Peru, Egypt, Sweden, Romania, Brazil, Malaysia, Congo, Nigeria, Egypt, Australia, of course, Saudi Arabia. I'll continue the rest. There's a few more. And also, just a reminder, the Menti code was 205206. I've got it up, it's working. So, Gura, please, if you could start the first global rounds off with your case, I'd appreciate. Go ahead.
Yeah, as Gaura is loading her presentation, I request everyone to look at the questions. It's a case related. All of you look at the questions at menti.com, and we will show the results at the end. And we have questions for the panelists as well. Go ahead, Gaura.
Thank you, Dr. Tan, for that warm introduction. It's my privilege to present the first global grand rounds of WSPOS. Our patient was a 9-year-old boy who presented to outpatient department with outward deviation of left eye noticed by parents since 5 years of age. His birth history was uneventful. He had attained motor milestones at appropriate age, and he was lagging in his studies due to delayed schooling. There was significant family history of mother having strabismus, the details of which I will be discussing later. The best corrected visual acuity in both eyes was 20/26/6 with a stereo acuity of 70 seconds of arc. As we can see, his face was symmetrical, and when he was fixing with the right eye, his head was straight. But when he took a fixation with the left eye, there was an abnormal head posture of right face turn. The Hirschberg corneal reflex was noted at 15 degrees exotropia and 15 degrees left hypotropia. The prism bar cover test revealed an exotropia of 45 prism diopters and a left hypotropia of 30 prism diopters, which was similar in right and left gaze. The left hypotropia increased in the up gaze, which was slightly more in the dextro elevation compared to that of the levo elevation. Both exotropia and hypotropia reduced significantly in the down gaze. This is a 9-gaze picture. As we can see in the primary gaze, there is an exotropia and a left hypotropia. In right gaze, there is a downshoot seen in the left eye. And in the left gaze, there is an over elevation in adduction, possibly due to pseudo-inferior oblique overaction due to limitation of elevation in the left eye. Now I would like all of you to concentrate on the ocular motility of the left eye in the up gaze. This is a photographic error of showing an adduction limitation, but there was complete adduction for this child. Although there was limitation of elevation in adduction of -4, with -3 limitation of elevation in straight up gaze and -3 limitation of elevation in abduction. There was divergence in up gaze, which gave the horizontal strabismus a V pattern. As we had elicited in the history, mother also was having strabismus. We examined her, and to our surprise, we found that she also had limitation of elevation in adduction, which was more compared to that of abduction. On reviewing the old photographs, the mother's photograph revealed she had a right face turn and a mild ptosis in the left eye. The child, at 6 months of age, had an orthotropia but developed a mild limitation of elevation when he was 3 years old, but there was evident limitation of elevation in the left eye with an exotropia at 5 years of age. The anterior segment examination was normal. The posterior segment examination showed an extorsion in the right eye. Considering the history and the clinical features, we made the diagnosis of exotropia, which was possibly a decompensated one, and a left hypotropia with a left eye familial Brown syndrome. At this point of time, I would want to know from the panelists their experience of familial Brown syndrome.
David, can I ask you to kick off?
Yeah, sure. First off, congratulations. That was a great presentation and a very interesting patient. I especially appreciated the picture in front of the Statue of Liberty, where I'm from New York. So as long as we're global, I like that very much. And, you know, it's interesting because the child, when they're in front of the Statue of Liberty, has to look up. And that's true of children all the time. They're always looking up at their parents. And so parents notice the Brown syndrome or the failure of elevation because children look up. And there's this concept that as children get older, Brown's goes away. And we don't see it as much in adults, but it always makes me think that now they're no longer looking up, right? I mean, adults are looking straight ahead or down. So I think it's just not as common to see. But to answer your question, how commonly you see familial Brown syndrome, my answer to you is now that I pay attention to it more than I did when I began my career, I see Brown syndrome and something else in the family. It's not always Brown syndrome in the parents, but there's something else that I see. And sometimes it's a superior oblique palsy, and sometimes it's another form of strabismus. I have one patient who I'm thinking of that had Brown syndrome, and the child had Duane syndrome and also had uveitis. So there are things that come together. And I think that that's going to be part of the key of what we talk about today, is that Brown syndrome isn't just one disease. And it leads us to start thinking about the genetic component of Brown syndrome, as well as the fact that there's a whole host of different changes that affect the ocular muscles that end up with a failure of elevation and adduction. And I congratulate you for your language use when you presented the case, because too many times we present a diagnosis rather than a description. And by example, I mean, when someone sees failure of depression in adduction, they say, oh, superior oblique palsy, or over elevation in adduction, inferior oblique overaction. So by using those words carefully, we're making sure that our thought process matches what we see. So first we describe what we see, and then we start looking for what are the changes that might cause it.
Thank you, David. Saurabh, do you have any inputs at this point of time?
So the first thing is, I would echo what David said. You know, there's a wonderful presentation and very clearly described. And it's really important when you see a squint patient to be able to describe what you see first before jumping to diagnosis. The problem is, especially in the UK, where we have orthoptists, our trainees are very used to getting a nice report of the eye movements, and they go right to the bottom and they read the diagnosis, and that's great. But you know, that's not how we do glaucoma, that's not how we do cataract, and that's not how we should do strabismus. So I think, you know, we should really describe what we see before we reach a diagnosis. I think it's a very interesting case. I think there are a few unusual things to it, and I'm sure we will discuss that as we go within the presentation. For example, this child having such good stereopsis in spite of having such a large deviation. I think that is very interesting, and I'm sure we'll come to that. Also, it's very unusual in Browns to have a hypertropia in down gaze. Usually the hypertropia is, you know, more in up gaze, maybe a little bit in primary gaze, but that's another very unusual thing. So in London, you know, London is such a diverse global city. So it depends where you work in London. I work in 4 different hospitals. It's like having 4 different practices. So yes, in some of the areas where there are large ethnic populations, you do see familial syndromes more commonly. So we do see some familial Browns. It's also interesting the things you see associated with Browns. For example, we see a contralateral Fortner palsy in some of these patients, so-called Fortner palsy, something to look for. And as David says, I think it is important when you see anybody with strabismus or anything that has genetic component to actually take the time to look at the family. You know, a lot of times in large cities with working parents, normally you may not see one of the parents or some of the siblings, and I think it is worthwhile taking some time to call them in to have a look at them.
Okay, thank you. Can you go to the next question, Gaurav?
Yes.
Saurabh, can you explain to us how often you see the horizontal deviation in Brown syndrome? Additionally, you can also give any genetic test you will do in this kind of situation. We will start with you and then we'll go back to David.
Right. Okay. So I have to say, not often. Okay. A lot of the Brown syndrome I see are children purely with limitation of elevation. Is primarily seen because the children are little. They look up at the parent. The parent notice one eye does not move as well as the other. That's the majority of the people I see. The few people I've seen with the more prominent Brown syndrome are those with hypertropia in primary gaze, who then come either because of that or they see that the lid is down on one side. It's obviously the lid is not down. It's just a it's a pseudotosis associated with the hypertropia. So I haven't, I have to say, seen very many patients with the horizontal deviation in Brown syndrome, which also made this case for me quite interesting. Now about genetic testing, my personal practice is not really to send people for genetic testing for Brown syndrome. I was always taught in medical school, and then I was taught in India that you only order a test if you're going to act on it, or it's going to change your management. And because it's not something I have seen a lot of, and I'm not sure it would necessarily change what I would do, or it would change the decision maybe of the family to have a second child. It's not something I do normally.
Okay. David, your quick thoughts?
Yeah, so I've seen a few kids with Brown syndrome who stick out that had significant deviation that I thought needed to be addressed at the time if we did surgical intervention, where I might see small deviations. Certainly you see the V pattern, and if I can act it out, if you think of the superior oblique as attaching, here's the trochlea and here's the superior oblique, and this is the classic shortened tendon. As they look up, the eye spins into abduction, and so sometimes you can get these deviations, certainly in up gaze, but in horizontal, in primary position, horizontal gaze, left and right gaze, generally I don't see large deviations. And I think Sarah brought up something very important in terms of the stereoacuity of this child, which must be occurring, I believe, when the child is turning his head and getting using his left eye for fixation, but using both eyes together, because I don't see another time. I think that's what we classically think of as the head position. The abnormal head position is to drive binocularity.
Thank you, David. We will move on. As Gaurav is going to the next slide, I just request everyone to answer the questions, similar questions on the menti.com. Code for today is 205, 206. And we have people joining in from Abu Dhabi, UAE, Colombia, Philippines, and Israel. Go ahead, Gaurav.
This is a representative video showing the force duction and the force traction test. The force duction test for the vertical recti muscles was negative. The force duction test for the horizontal recti muscles was negative, while the guidance exaggerated force duction test was positive for the superior oblique. As you can see here, the superior oblique is too tight. This is just a representative picture to elicit the exaggerated force traction test of chitin, wherein in the right eye you can see there is tight superior oblique, while in the left eye there is a lax superior oblique. In our patient, there was tight left superior oblique, and hence we went ahead with a left superior oblique tenectomy with bilateral lateral rectus recession. The left superior oblique was approached the superior temporal quadrant. The whole tendon was hooked and a segment of superior oblique was excised using a Westcott scissors. The force traction test post-tenectomy was free. Now I would want to know
Gaurav,
from the
I'm sorry, I'm
panelists.
going to interrupt you I'm sorry to interrupt for a second. Was that a tenectomy or a tenotomy?
Tenectomy, a segment of superior oblique tendon was excised.
Okay.
So I would want to know what would different you would have done in this case.
Okay, David, you want to go?
Sure.
Kim,
Yeah.
feel free to join in. as well. David, go ahead.
Yeah, so great videos, and I love the forced adductions test. We do it in every patient because I think that for residents and fellows, your hands have to get used to how that feels. And of course, you retropulse the eye when you're doing the obliques, and you elevate the eye when you're doing the recti muscles to put them on stretch a little bit. I use that instead of scanning everyone. I know we'll talk a little bit about imaging later, but because there are multiple issues that can occur that all look like a failure of elevation and adduction, your surgical choice has to be, you have to have multiple choices available to you and then make a decision. In general, I don't like with a superior oblique a tenotomy or a tenectomy, certainly not alone. And I worry about creating essentially a superior oblique palsy by doing that procedure. Not that it doesn't work, and not that it wasn't one of the first things described by Brown to do. And typically, if I think it's the superior oblique, I've had success with doing either a so-called chicken stitch where you hang the superior oblique back, or and I was taught this in Brazil, and I've had good success with this. One of our fellows, Cynthia Gomi, taught me this, and it's the beauty of learning from people from all over the world. It's to recess the superior oblique to the other side of the superior rectus, about 8 millimeters back, and I do that in adjustable suture, and I repetitively do the forced ductions in the operating room until I think that I've balanced my forced ductions on each side, and then I tie it down so that I've matched my ductions on each side. So that's my typical go-to procedure. In this child, I think you're also going to have to address the lateral rectus, or you have to address the exotropia.
Saurabh?
So yes, the first thing to say, the forced duction test is very important in this case, because one of the differentials could have been a monochore elevation deficit syndrome, because the child has limited elevation in adduction and abduction, although it is more prominent in adductions or something. So I think absolutely is very important. In the UK, all residents have to complete a certain number of forced duction tests to actually get to the program. So I have a lot of requests for people to come on my list and do forced duction testing. So so we do a lot of it for that reason, as well as for its diagnostic purposes. So when I started, my first rule about treating Brown syndrome was try not to operate on them if you can possibly get away with not operating on them. But we absolutely had to. Like David, I'm a little bit concerned about the possibility of creating a fourth nerve palsy. So either if you do a tenotomy, then I do inferior oblique weakening at the same time. But that's another muscle you may not want to touch. I used to do a silicone band, just a retinal 240 band. I used to use that to elongate the tendon by about 5 millimeters. But lately I've switched to using a chicken suture, because it's a suture bridge. It is quite easy to do. It's easy to reverse. And I suppose the only difference between that and tenotomy is, at least mentally, I feel, well, I know where the two ends are. And if I do create a superior oblique palsy, I can bring them together, although I've never had to. The only other thing I'll say is, in my hands, I found that you do this weakening procedure, but you don't get the effect straight away. So you might still see some hypertrophy immediately postoperatively, but it does tend to get better. So wait a bit before you go in again.
Okay.
Yeah, Ramesh, I want to just echo that. I think that what you just heard was great advice, and everybody should be carefully listening to that. There are a couple other procedures that I've used. The split tendon, I like that very much because I can control the distance and the lengthening. I don't use the superior oblique expander, in part because I've always been concerned about inflammation, and I live an hour away from Ken Wright, who described it. So anybody who really wanted that, very honestly, I've sent people up, so I don't have much experience with it. Additionally, there's a stripping procedure that has been described in Spain and in Brazil, where you can thin out the superior oblique and make sure that it glides through the trochlea to recreate normal physiology in the surgery. I haven't done it, but the videos I've seen are quite impressive, and the surgeons very good who have described that.
Kim, you want to have any opinion on this? You have
no, I think for time, Ramesh, I think I would just echo those same thoughts. Okay. I must say, the idea of doing your best not to operate on Browns and then doing the minimum I'm anxious to see your result with this tenectomy, given the panel feeling was that they would have done something else at the same time. So I might come back and add something at the end of the discussion.
Sure, that's great.
After this case. So we'll let Gaurav continue.
Yeah. As Gaurav is continuing, with people from Vietnam, Myanmar, Portugal, Ecuador, people are joining. Welcome everyone. Again, the Menti passcode for today is 205-206. Go ahead, Gaurav.
The first post-operative day, there was a left hypertropia of 14 prism diopters for distance and 16 prism diopters for near. But in the subsequent follow-up, the hypertropia reduced to just 5 prism diopters for distance and 7 prism diopters for near. His abnormal head posture had resolved and ocular motility had improved. We now want to present a case 2, which was presented like a brown-like picture but was not exactly Brown syndrome. He was a 7-year-old boy who parents noticed that he had a right head tilt and a right face turn since 3 years of age. His birth history was uneventful. The best corrected visual acuity in both eyes was 20, 25, and 6.6. The stereo acuity measured was 200 seconds of hour. As you can see in this, the primary gaze, there is a small exotropia of 8 prism diopters and a right hypotropia of 16 prism diopters. The right hypotropia increased in the left gaze and in the left head tilt. Although the measurements in the up gaze were not available, the extraocular motility pattern showed there was -4 limitation of elevation in adduction, with -3 limitation of elevation in the straight up gaze, with near normal elevation in abduction in the right eye. The anterior segment examination was normal. The fundus revealed the right eye had intorsion and the left eye had extorsion. We requested an MRI orbits for this child. On reviewing the literature of imaging findings in congenital Brown syndrome, Senner et al. Have described the enlargement of tendon trochlea complex in congenital Brown syndrome. They also say that clinically it does not give a clue about the outcome of the disease. A study by Bola et al. Have discussed 3 congenital Brown syndrome having significant imaging findings. In one of their congenital Brown syndrome, they found an inferior displacement of lateral rectus pulley with a normal superior oblique tendon trochlea complex. And the other 2 congenital Brown syndrome cases had ipsilateral superior oblique palsy, which was confirmed on MRI by atrophy or the absence of superior oblique belly. This is the MRI image of our patient, where we can see the right superior oblique belly was thinner compared to that on the left side. The forced duction test was in the right eye was negative for all rectus muscle except for the inferior rectus, which was 2+ tight. And the forced traction test showed right eye lacked superior oblique. Here, I would want to know from the panelists what would be their further surgical plan.
Gaurav, you might want to go back to the MRI. I just had 2 questions. When do you get imaging and what you get on imaging? David, you can begin.
Yeah, I mean, I know why you're asking this question. I mean, think about it just for a second. What you heard in the description of those articles is that you can see an atrophic superior oblique trochlear complex. You can see a hypertrophic superior oblique trochlear complex. You can see a downward shifted lateral rectus. So, and all of those we call congenital Brown syndrome, but they have completely different pathophysiologies. As Saurabh said earlier, you can see congenital fibrosis of the inferior rectus that would mimic this also, where you might have a failure of elevation in adduction, but also a failure in abduction. So we have all, that's why it's so important to describe what you see rather than give it a diagnosis. So we call all these the same thing. And it's why when you look at a compilation of surgical results, and if someone does all these patients the same procedure, then they may not get the same results because they have a different pathophysiology. So this raises the issue. And that's why forced ductions to me are so important, because it really does help drive my, my decision-making. I use forced ductions in lieu of the imaging, unless it's an acquired Brown syndrome, then I might image. But if it's a congenital Brown syndrome, I typically don't image, and I use the examination and the forced ductions in the operating room to guide me for what I need to do. I'm curious to see what everyone else does.
Saurabh?
Yeah, so, the first thing to say is if I have a big vertical deviation, I quite like to do an infraoblique antrization rather than infraoblique recession. I find it gives me really good anti-elevation. So if you're already trying to stop an eye going up, I think an infraoblique antrization really does a very good job. In fact, even in a DVD without infraoblique overaction, I prefer it to a superior rectus recession just because you get such good results. So I think that's the first thing. Recessing the inferior rectus is always a bit of a tricky thing, especially in a child, because you really want to try and separate out the lower lid retractors because you really do not want to give them any lower lid lag. And it's quite easy to do. So I agree with you. I wouldn't do more than 4 millimeters really of inferior rectus if I absolutely had to. So the question about what more surgery would you do, it depends on what you would end. I don't know, Gaurav, if you showed that, but it depends on what. And again, just because there's a small deviation doesn't mean you need to do more surgery. And I think this is, I keep on saying this to all my residents. You need to have an indication for an operation, not that the numbers are not close to zero. So, I would like to give them some time to settle, see what, see what we end up with, because you get this long-term remodeling of the sarcomere. So just give them some time and then see. And the last thing to say is I treat all redos as a new patient. So you look at what deviations you've got, what pattern you've got, and then decide on the amount of surgery. So I would really like to wait and see what they end up with and then decide.
Kim, you had something to say? Yeah.
Yeah, sorry. David, could I follow up something you said? You talked about the difference between acquired and congenital. And you said you'd always image the acquired ones. With this particular case, is there, what was the indication to image? Why would you have imaged this case?
I don't know if I would have. I mean, the deviation was interesting, right? I mean, you're looking at what looks like a hypotropic superior. It's a small superior oblique complex on the right. Yet you have failure of elevation on the right eye, and so it's interesting to see that. But I'm not sure I would have necessarily imaged this child. Would you have, Kim?
It's hard because I think if both these cases, there's a suggestion of change. They're presented. You said that these children present when they first look up to their parents, and relatively speaking, even the first case, the child, I thought in the Statue of Liberty photo looked pretty good, and there does seem to be some evolution of the signs. And probably apart from that, I'm not sure I had any other reason to image this child. So I think I'm sort of thinking in the mindset of all around the world where, including in Sydney, we often don't have easy access to MRIs. I often look pretty hard for reasons to whether the hospital pays for it or the patient pays for it in another country. I do want a reason to push the parents that way. And I'm not sure I would have imaged this child actually.
Okay, can you go back to the 9 gaze pictures and abnormal head posture, Gaurav? Abnormal head posture, please. So this patient had a right face turn. He was in fact preferring that position. And if you can go to the next slide. So it was looking like generally people will avoid that gaze. They will have an opposite gaze. So this patient had multiple patients. He already had a kind of imaging done 3 times for this patient because there was inconsistent abnormal head posture. And the confusion was more because of the MRI finding here. Because the brown eye is showing a hypoplastic superior oblique. And as Gaura, go to the next slide, I think she said all the rectus muscle, the oblique muscle was not tight. This was adding another confusion here. Sometimes the investigation can create some more confusions. So actually, the inferior rectus was a bit tight. That's where we thought that it's a kind of brown-like picture because of the congenital cranial dysnervation syndrome, where superior oblique and the inferior rectus are co-contact. Go ahead, Gaura. We can discuss some more after the post-op outcome.
The surgery performed primarily was left eye inferior oblique recession. There was not much improvement in the abnormal head posture or the motility following this surgery. Hence, we went ahead with right eye inferior rectus recession of 3.25 millimeters. In the subsequent follow-up at 2 months, the abnormal head posture had resolved and the motility had improved.
What did the inferior rectus look like in the operating room?
It was completely normal, David. We did not explore the superior oblique because it was not tight and we didn't want to make one more incision. That way it created a kind of, too many things. The audience are asking one of the questions for panel, what about head tilt test? Does the head tilt test really help in Brown syndrome patient? What do you think, David?
No. I mean, the three-step test was created for paretic muscle. And I think that you have to look at what's in front of you and look at deductions to see. And you had to explain, I mean, it was interesting because this is the forced ductions in the operating room. You had a lax superior oblique tendon, yet you had an eye that wouldn't go up, right? So next looking at the inferior rectus was the issue. And I think that what you did makes sense. And that's why, as Kim said, I'm not always sure what to do with the MRI. In imaging, the forced ductions and the deviation in the office mean more to me. And I think that you now have raised the cranial disinnervation issue, and I think that this is I think Brodsky was the first one to describe it. Jim Ellis in Virginia was the first one to tell me about it. I hadn't realized that if you look at the other eye, Brown's plus. If you look at the other eye, you can see something else that might be wrong. And that's when you start seeing some kids who look like they have the inferior rectus or fibrosis. You're looking at some sort of disinnervation that gives you this failure of elevation, and that's why you scratch your head sometimes.
There is one more question. This is for Saurabh, I guess. Anteriorization of inferior oblique with or without deformity. What's your preference?
So I think so here the thing is, if you anteriorize muscle, you want to prevent a J deformity because you don't want to stretch the neurovascular bundle so much that you get an anti-elevation syndrome. So what I say is, firstly, detach the muscle as close to the sclera as you possibly can, and the way you're doing it right is when you take the muscle of the sclera, there should be no bleeding, because you are dissecting the tendinous fibers at that stage. So if your muscle's bleeding when you're detaching it, that means you're too anterior. So really you want to detach it as close to its insertion as possible. And then you really want to attach it next to the inferior rectus insertion, to the lateral edge. So you don't want to go even 1 millimeter above that, because that's when you get this J deformity and the anti-elevation. And it's quite easy to actually go above that, because you hook the inferior rectus, you draw it up towards you, and you think insertion is more superior than what it is. So you really need to be really careful to go right next to it, not above. It doesn't matter if you go a bit below, to be honest. That's all right. You may not anteriorize quite so much, but you won't have an anti-elevation syndrome.
Yeah, and Ramesh, when we're operating, for me, I love operating on the inferior oblique. I mean, if the patient has fusion, operating on the inferior oblique, you end up with almost anything you do seems to work fairly well. Conversely, operating the superior oblique increases your risk and increases the potential for problems in my hands. So my thought process, whenever I can, I end up with doing, I guess, mental gymnastics that takes me away from the superior oblique, unless I have to.
Yeah. Kim, you have any thoughts?
Not to add to that, I was going to ask Guru, can I go back to the first case, Guru? And Saurabh touched on this. You mentioned in your results, a fantastic surgical result. And the child did have a nice sensory status preoperatively. And I see there is, in the follow, there is some, I mean, that's a fantastic result. I was interested to know, were there any symptoms in down gaze? Was their stereopsis still intact after surgery?
Yeah, stereopsis was intact and he did not have any torsion or anything. He still has this elevation deficit. It's not completely gone in spite of doing tenotomy. There was a kind of discussion on what's the best procedure. Personally, I used to do tenotomy for everyone, but in these types where it is significantly tight, I go for tenotomy. Otherwise, I prefer spacers as well. He was not symptomatic. This child was not at all symptomatic post-operatively, both from double vision or torsion point of view.
That's fantastic. I mean, yeah, just shows you there's many ways to skin a cat and you get there in the end. That's a fantastic result.
Gaura, you can go to the last slide. After that, each panel, if they have any kind of message from this case, I think we can finalize.
Yes, from these two cases, I would want to reiterate that horizontal deviation is associated in 30 to 40% of Brown syndrome and should be taken into consideration when planning for surgery. 2 to 5% of the conditions are familial, and one should try to elicit the inheritance pattern and, if possible, to send for genetic analysis. There are various choices for Brown syndrome, and it is always left up to the surgeon's discretion to decide on table after the forced duction and the forced traction test. In spite of detailed clinical and radiological investigation, there is always a diagnostic dilemma in few cases, which provokes us to have further studies to understand the pathophysiology of this condition. And trochlear nerve hypoplasia can lead to either a frank superior oblique palsy or sometimes a misinnervation from the third cranial nerve, leading to intrinsic structural changes pointing towards a congenital cranial disinnervation syndrome, manifesting sometimes as a Brown syndrome. Thank you.
Thank you, Gaura, for the nice summary of these two cases. For me, as a take home, I think for me, the forced traction test is still a very, very, very important test in addition to the 9-gaze clinical measurements. Radiology might help, especially in the CCDS variety, but it's not the only thing. This is what I would take from these two cases. David, Kim, and Saurabh, Dominic, Nicolene, if you have any one thought, please share to everyone.
Yes, I do have a thought. I think that in the end, we are going to have to rename all of these disorders because it's confusing to the learner to call it Brown syndrome when it may be a cranial disinnervation. And when you have a cranial disinnervation, you may have a completely different appearance than a pathophysiology right at the trochlea superior oblique from a developmental issue in the way it formed embryologically. That's two different diseases with the same phenotypical expression. And so we're going to have to start separating these different forms of failure of elevation and adduction. Otherwise, we're going to continue to be confused and mixing them all together. And I think that's the mistake that we've been making. 10 years from now or sooner, we're going to have different words to describe all of this.
Thank you, David. Saurabh?
I think the one thing I would say, and that's in relation to the question we were asked, this three-step test or a three-step test or the head position test works best for a neurological problem when the single muscle is involved. It's not a test to use when there's a restrictive pathology. And there's something I tell the trainees all the time, because anytime they see a hypertropia, they want, or chin or a head tilt, they want to do a three-step test. And the three-step test will not work for you. It will not give you the answer. The three-step test will tell you which is the underacting muscle, which will work for a single muscle neurological problem. It doesn't work in a restrictive problem.
Thank you, Saurabh. Dominic?
Yes, I think really you're right. The testing is very important also, but as I have access very easily to MRI, I do for most of my patients. So that's why, and sometimes I think it's really helping if you can have that. And about surgery, I appreciate your results. It's a great results for the patients. Thank you.
Thank you, Dominic. Nicolene, you have any additions?
No, the only thing David mentioned that sort in the bypass, but as you do the first duction test, it's very important. But he also described that you can do it during surgery again in these cases, and after you make a loop or whatever, and just try if the eye movement is normal or not, if you have to do less or more. I think that's also was something that should be taken into account when you do surgery on these cases.
Thank you, Nicolene, for that. Kim, any final thoughts?
Not much. Just again, I think the thought about differentiating these, in particular in light of, I think the habit of calling it Brown syndrome and assuming it's congenital. I think we're realizing there's different etiologies, in particular with there's different acquired etiologies, opens the door to treating them a bit differently when they first come in your door. I think I would refer everybody to the Brown's webinar earlier on in the year in that respect.
Thank you, Kim. Thank you, Gaura. That was a fantastic presentation. Thank you all the panelists. Now I invite Jamila to share her 2 cases. We will be asking the questions on menti.com. 205, 206 is the code for that. Please scroll down and see the questions. I will prepare the answers. I will show the results after Jamila presents. Jamila, all yours. There's somebody joining from Kenya now. It's fantastic to have somebody from Kenya now. Jamila, please go ahead.
Hello, everyone. I'm really happy to be here. Thank you for the very kind introduction. I'll present 2 cases from our service, crystal clear knot. So the first case, 16-year-old previously healthy female patient. She had bilateral corneal changes, referred to us for evaluation. She was originally treated with topical steroid drops, but no improvement noted. Patient is not bothered by blurred vision, no photophobia, discharge, or eye pain, and her medical history is not relevant to the presentation. Her exam is shown normal and significant only for intrastromal corneal flick-like changes, and she's myopic and has astigmatism in both eyes. This is a slit lamp photo which shows the corneal flick-like changes, and as you can see, it's centered in the center of the cornea. And to show it better, this another slit lamp photo which shows these lesions. And as you can see, it might be affecting the anterior part of the corneal stroma. And this is a slit lamp photo, very beautiful picture with the sclerotic scatter technique, which better define these lesions. So to go over the sclerotic scatter technique for imaging the cornea, these pictures are taken from this website of Ophthalmic Photographers Society. And as you can see in the picture in your left, your light and your focus is kind of aligned in the same spot. But with sclerotic scatter, your light are dissociated from your focus. And how you can do that, as shown by these pictures. So if you look at the left picture first, and you can see your focus as shown by an X, and the light is on top of your focus. And this is most of the direct illumination slit lamp microscopy techniques. And to do sclerotic scatter techniques, you need to loose the knob on the slit lamp anti-clockwise and dissociate your light from your focus, either to your right and to your left. And this is shown on the right picture. So I'll go back to this picture, and I want to turn, before I share the anterior segment OCT for this patient, turn to our discussant. Any thoughts of what's going on here?
Yeah. Thanks, Jamila. That's amazing photos. They're wonderful. Dominique, would you like to comment on the case so far? 16-year-old girl.
Yes, I think it's very nice pictures, and I see the technique is very interesting because you can see very well, and also you can have maybe in a very thin slit lamp, maybe you can have all the all the thickness of the cornea. That could be interesting also.
So do you use this technique regularly in your clinical examination?
No, not this way.
Okay. All right. Thanks. We'll come back to you, Dominique. Nicolene?
Well, there are
any comments?
And I think this technique is very important. I learned it during residency, and I use it a lot, but children, it's not always that easy to do it because they sort of keep on moving around. But if they get a bit older, it's a nice technique to get the to know how deep the lesions are, and that might be important to differential diagnosis.
Good. Could I ask you, Jamila's about to go on, she gave us her answer in a moment. What would your next step with this case be? In terms of investigations, what's your next step?
Well, I think I would make something like an anterior segment OCT or a pentacam to, well, because we have these nice techniques now to differentiate between the layers and to see where the abnormalities
Excellent. Excellent. On that
Yes.
note, we'll let Jamila continue. Thank you.
Yes, I think imaging is very important also, right?
So we did the anterior segment OCT for this patient, and you can see the anterior segment of both eyes. And interestingly, the corneal changes affect the full thickness of the cornea. It's not like what is shown in the slit lamp photo, and it's panstromal. And as you can see by the white arrows, that it's mainly affecting the center of the cornea. So I'll go ahead with the next case. 9-year-old previously healthy female patient with bilateral corneal changes referred to us with diagnosis of Tyson SPK, superficial punctate keratitis, and she was originally treated for it. She had no symptoms except for slight burning sensations when drops are applied. No medical history related to this. There's a family history of frequent cold sores. This is her exam. Significant for bilateral lid changes of meibomian gland dysfunction, and the cornea shows very fine punctate epithelial erosions with subepithelial lesions and heaping of the epithelium. Otherwise, it's normal. That's the slit lamp photo, as you can see, and you can see these white corneal changes, mainly subepithelially and in the anterior stroma. And with also the sclerotic scatter technique, you can really better visualize these changes. So this patient is interesting because first, giving the lid changes, she was started on fluoromethalone, oral bolatrim drops, and oral erythromycin dose for blepharokeratoconjunctivitis that she had. 1 month later, the lid margins improved, but the corneal findings looked unchanged. So in subsequent visits, we did corneal sensation testing and reduced corneal sensation in both eyes. And given the heaping of the epithelium that was seen initially in the exam and the grandmother frequent cold sores, she was started on Zergan to treat a possible unusual presentation of herpetic keratitis. Symptomatically, she got better, but the corneal changes remains unchanged. So along with previous treatments, we decided to schedule the patient for examination under anesthesia for corneal scrapes, for possible microsporidial infection, tear film PCR for viral etiology, and anterior segment OCT for corneal dystrophy.
Jamila, can we just pause there for a sec?
Yep.
Jamila,
Sure.
can we just go back? Yeah, that's great. Could I ask our panelists, because again, Jamila is saying what they did with their case. Dominique, and could you start, and Nicoline, could you comment, is that what you do next, or can you, would you have a different pathway? Or would you be giving this child an examination under anesthesia? Is that where you'd be taking this child?
I think this is very important. Jamila, you just present this case. It's very interesting because, of course, I think you have to be sure it's not an infection. So that's why I think scatter is really important. And I really think it's the first step. It's probably not the diagnosis, but you have the first step to do. And so, of course, you cannot go through and think it's another thing, because if you just pass this problem, you have big problems after. So, I mean, you need to be sure it's not an infection. So I think it's a good step.
Nicoline, is this your pathway too? EUA?
Well, these are very nice cases, but what strikes me in both cases, but also in this case, is that the patient doesn't have many problems. They don't have complaints, they don't have a red eye, or I don't know if I had it in the past, but the eye, apart from the problem in the cornea, is rather quiet. So that would probably make me think more towards non-infectious disease. But of course, you have to be very careful. It would be nice to do scrapings, but well, it's something you have to weigh if you do an explanation under anesthesia, I think.
Okay, I suppose there's
There
a few
is,
questions from the
some
audience too.
Yeah.
Sorry, mate.
You
Ramesh.
want to go ahead? Go ahead, Kim. Yeah.
I just wanted
The
to,
first
I'll ask one
from the
question. You go ahead, Ramesh.
Okay. Thanks, Kim. There are questions from the audience. Does the type of anti-segment matters? The OCT, anti-segment OCT. Does the type of anti-segment OCT matters in these cases? That's the first question. And the second question is, bilateral herpetic stromal keratitis, can it be bilateral? These are the two questions coming from audience. Dominic, you want to go first, and then Nicolene?
Okay, good. Yes, that's very interesting, of course, questions. First, it could be bilateral. Of course, usually when it's bilateral, there is immune dysfunction, so it's easier to have this problem. And you said the first question. Can you tell me back, Ramesh, the first question you had?
Type of anti-segment OCTs. Do they matter?
Yes, it matters because, of course, if you have an OCT with a very good resolution, it's easier. I think you can have other imaging like UBM, which may be not more informative, but also confocal. When you have a confocal microscope, it could be very useful for keratitis and fungal keratitis because you have special findings. And so I think really the imaging, when you can do it, because 16 years old is very good because you can have it, but 9 years old, sometimes it's very difficult. I said Nicolene, because in children, it's sometimes difficult to have good imaging. So that's my answer. If you can go on, Nicolene, it will be yours.
Yeah, I suppose what we're asking Dominic and Nicolene is, that's what I was asking about the anesthesia. What anterior segment OCT do you two use? Because not all of them require an intraoperative OCT. So what do you have in your clinic?
Oh, in my clinic, I have 2 OCT. You mean the name, or you mean?
So what do you use? Only intraoperative OCT for these fine images of the anterior segment, or do you use a different instrument?
I can use different instruments because I have intraoperative OCT, but I think the resolution is not very good, and I have OCT in the clinic, and I have also confocal. So in both three, sometimes you well, that's nice when you have that, and UBM also intraoperative. So I think I have multiple choices, but it doesn't matter if you have the good one when you see the images. So that's good.
I do not have intraoperative OCT. We only have anterior segment OCT at the outpatient department, and we have Pentacam. And my experience is that these images can be taken at a quite young age. Well, sometimes children of 3 or 4 years we can get them behind the apparatus, and then often I have to help, or somebody has to help to just take the attention and help the one who has to image. But I can't use it under anesthesia, so I do it at the department, and if they are too small, I can't. And for the question about the bilaterality, it is possible. And the other infection that it's not always thought of, but I've seen 2 cases, was the Epstein-Barr virus infection that can have the same, can look similar to HSV. So that's also something to keep in mind if you do cultures.
Thank you. I might follow that up in a moment. Jamila, do you want to keep going? Sorry to interrupt.
So the reason why we considered corneal scrapes for this patient for microsporidial infection, these pictures are courtesy of Dr. Wang, a 13-year-old male patient who had a clinical presentation similar to our patient. And as you can see from the photos, they look kind of similar. So we went ahead with the corneal scrapes and no microsporidia and gram stain, and the viral cultures came back negative. This is the external eye photo and the intraoperative OCT as shown. And before I share the anterior segment OCT that would give away the diagnosis, I want to turn out to our discussant for their thoughts on the anterior segment OCT findings.
Nicolene, you want to start this time?
Well, they're very superficial. That's something we can see. So we have to think about diseases that are just or under the epithelium. And then, of course, well, viral infections are in the DD, but you can also think about corneal dystrophy, especially as it are both eyes, and there are not so many complaints in a young child. So that's, I think, those are the main things you have to think about when I would see an OCT like this, together with history. But I don't think what.
Thank you. Dominique, do you want to make some comments on the findings so far?
Yes, thank you, Kim. I really think when you see the image, well, when you have the cultures that are all negative, I think it's really reassuring for the child. And when you just see the OCT, I think we can just find some white dots in the external layers of the cornea. So we can see that, and also that the stroma is not so regular. So it's probably a sign, and so I'm sure Jamila will be more informative with next slides. But you can just look at this first.
Yeah.
Okay, thank you very much. And Saurabh and David, Ramesh, if you have any pressing things you want to say, please feel free to interrupt. Otherwise, we'll let Jamila reveal all the answers. Okay, okay, Jamila.
So as you can see with the external eye photo, the dryness of the cornea, and as we mentioned, there is hyperreflective white specks, and mainly in the anterior stroma and subepithelially as the white arrows shown. And so our thoughts for the diagnosis of both patients who had like somewhat similar presentation but different corneal findings with the anterior segment OCT findings as well. So we went ahead with genetic testing for both patients.
Jamila, can I interrupt you at this point of time? Panelist, what do you think? Do you think it's Thygesson's SPK? Because this patient was referred with that diagnosis. So if yes, why? If not, why? Maybe Dominic?
So I don't think you can go on the diagnosis of just SPK and just dry eye, because when just looking at the dots and the prints and also the repartition of the dryness, if you can go back to the other slide, Jamila, the last one. So this repartition is not something that you can see on the regular dry eye. So I will think that we definitely must go to genetic testing and to a diagnosis which is different.
Nicolene?
Go on the next slide if you want.
Well, I imagine that if you don't have all these nice OCTs, etc., that it comes to mind, and I think it's Tigerson is a disease that's not diagnosed that often and sometimes overlooked. So if you see very slight dots very superficially with staining of punctates of the epithelium, it can be UDD. But if you see the pictures, then yeah, I don't think it is. But.
Okay, at this stage, with all the information for the case 1 as well as case 2, could be the panelists' top 2 diagnoses for both the cases? I know genetics is not available for all of us around the world. If you want to make a clinical diagnosis and manage these children, what could be the top 2 diagnoses from both of you? Dominic can go first and then Nicolene. For both cases.
For corneal dystrophies, we have some different findings, and which is sometimes very strange is you can have different pictures for just one gene, and sometimes different genes for one picture. I mean, from one finding, from clinical finding. So it's always very complicated to be sure of the diagnosis, like Renault or Cogan dystrophy. And for the second one, I probably will discuss something special. Like you can see in Cogan dystrophies, you can have fingerprints on the cornea, and could be this possibility. I know. And so about the repetition also of the dryness on the cornea. So always difficult, and much more difficult when you have access to genetic find. So sometimes you just wait and say, okay, I think I was good, but sometimes, oh, I was really wrong. So you must be very, to be really very, you have to know that we don't know everything about genetics.
Nicolene, any comments before Jamila goes ahead with the slides?
No, I think if you would think dystrophies, I would say that the first one is more inwards into the macular dystrophies, and the other one possibly in the granular dystrophies, if you look at how they present. But I'm sure that Jamila is going to.
Before Jamila goes on, could I relay a question from the audience to you too? The question was, what do you think of a differential diagnosis for case 1 being Schneider's differential dystrophy? So could the top one be Schneider's? And the questioner also asks, what do you make of the cornea, the interlesion cornea being clear? Does that mean anything? There was another question about Tigerson's, but we'll come back to that. So the questioner asked, do you think the case 1, the top photo, could be Schneider's?
Well, I have if I recall, Schneider's is more disc-like dystrophy, and these are more. This looks more macular, so well, yeah.
Just pursuing that result, I agree, Nicolene. If you're saying that looks like macula, what about the interlesion cornea being very clear? Does that mean much, or is that a function of her being 16?
That might be related to the fact that she's 16, I think, because these dystrophies also, they deteriorate in time. So that might be, that's a good point.
That's not my point. That's one of the questioners. Thank you for that, for clearing that up. All right. How about you go on, Jamila, and we'll get back to the questions.
Thank you. So we went ahead with genetic testing, and corneal dystrophy sequencing panel came back positive for CHST6, and the patient has confirmed macular corneal dystrophy. And for the second patient, the panel came back positive for TGFBI gene, and pathogenic variant in TGFBI gene been reported in variety of corneal dystrophies, lattice, granular, Avellino, Thiel-Pinky, and Reese-Buckler. And for us, giving the patient's findings, corneal findings At the moment, she's 16-year-old. We think she will develop in the future as she grows older a more characteristic pattern similar to Reese-Buckler corneal dystrophy. So take-home lessons: corneal dystrophy in children often misdiagnosed unless there is a clear family history. Corneal sensation in anterior stromal dystrophies can be reduced. Secluded scatter technique is a good way of photographing these dystrophies in children. And different disorders caused by mutations in the same gene are called allelic disorders. And if genetic testing is not readily available, consider corneal dystrophy as a diagnosis in unusual cases. And thank you so much.
That's amazing cases, Jamila. Thank you so much, and very nicely presented with wonderful photos. Can you put your genetic slide back up, the results? Could you go back 2 slides? Dominic, yeah. What do you think? Any comments? Can you give us your opinions on? You already touched on genetic testing for these diseases.
It's really outstanding cases, and because you have all the images, and it's really very nice presentation, and thank you, Jamila. And of course, it appears like macular corneal dystrophy or Corneal, when you have CHSTC6, it's good because you have the diagnosis, but you never know exactly what will be the future for the child. So that's why it's a bit complicated, because it's not so easy. And if you have no family history, it's always complicated. If we go to the second case, also, this is exactly what I was talking about, TGFB1 gene, because you can have multiple clinical forms for only one gene. And so that's why it's interesting that you said, because he's 9, and so it's probably much more Reise-Buckler corneal dystrophy. And so what is important is, because you have, at the time, you have the diagnosis, and so the parents are reassured. So that's important for the parents, because they know why the child will not see very well, or may have also surgery or something like this. Also important for the children of this child, because they may have, and also important if we can have one time maybe access to gene therapy. So all of these is an interest for the genetic testing, and I really understand that it is very expensive and not so easy to access. So it is important because the parents know, and we have the diagnosis for the child, and the follow-up also is very good to have.
Thank you very much. Nicoline, could I ask your comments? How you address these patients? You have these genetic testing available, I'm sure. What happens?
Yes, we have.
Two things I'd like. Sorry, continue.
Pardon? Yes, well, we do the testing as well, and what's important in our country, but I don't know if that's the case in other countries as well, because in our country, genetic testing is free for children. So, and if they are 18 years or older, they have to pay for it, and then it's very expensive. So that's also a reason for us to test when they're under 18. And for the rest, I agree with all Nick has said, that it's often important, not it's for the patient, for the parent, also for doctors that are going to see the child in the future, so they know what's on, and they are not going to start cultures again, etc., etc. What you have to do the first time to do a workup. But if the child comes back with punctates and tearing or deteriorating vision, you know what the diagnosis is, and you don't have to go through all the spectrum again.
That's great. That's a very good point, Nicoline. So say whether it's months or years down the track and the child's worse and more symptomatic, with erosions, how do you treat that? The child, you said where they had no pain. Yeah. So now they're becoming painful with erosions.
Yeah, well, you have options to start with contact lenses, for example, when they really get complaints with combined with lubricants. That's, I think, the first choice. And then if they have more problems in the future, or when their vision really deteriorates, then you can do other treatments. Some of the dystrophies can be treated by excimer laser, but you have to be careful because especially in the granular ones, sometimes they make awful scars, so you have to be careful. And if the lesions are more into the stroma, you can do either anterior lamellar keratoplasty or a full thickness, of course, but the anterior lamellar is preferred if the endothelium is normal. So that would be my approach. But if they have no complaints and their vision is good, then I think we shouldn't bother them with contact lenses and lubricants, etc.
That's great. Thanks.
Okay.
Dominique? Yeah.
Yes. I think even if they don't complain, I give them lubricants, and I try high powerful lubricants, because I think we have a lot of different possibilities with lubricants, and so I think it's useful because it keeps the last cells in good shape. I mean, but of course for contact lens, I don't go in this first line if they don't complain of anything. It could be also when they have a really decreased vision and really very, very high dryness. It could be scleral contact lens, because it creates anterior chamber with really wet. So it can be useful before surgery. I really try to avoid a laser, because in most of time the laser is maybe good in the first time, but after can be scars and with fibrosis. And so that's why I'm not really fond of laser. So my first choice is definitely lubricant in every case.
Excellent. Do you find punctal plugs help too?
Well, it could be an option. It could be an option. It must be also controlled, because sometimes it gets inflammation when you have punctal plugs, but it could be a good option to have that.
That's great. Sarah or David or
Kim,
Ramesh?
I'm sorry. Yeah, I do. I wanted to ask Dominique a question. You said you use lubricants, but I know that having traveled around the world, that different lubricants aren't always available in different countries. For example, in the United States, we don't have HA-based lubricants. Are there lubricants that are your favorites? What kind, and what do you stay away from in the lubricant, like preservatives, etc.? I'm just curious to see what you use.
David, you are right. It's such easy in Europe, probably because I use preservative-free lubricants for sure, because it's important, because it will be all the life for the child, and also I use hyaluronate of sodium hyaluronate, because I think it's really important. But I can't describe all the new lubricants, but they have a very good option on osmolarity, for instance. And in this osmolarity retainer, it's very good because the cells are much more hydrated. So you are absolutely right. Sometimes you don't have access to preservative-free lubricants, and so that's why probably some will not give some drops first.
Ramesh, Saurabh?
Yeah, nothing as such. I just wanted to share the results with everyone for both the cases. We had some questions, and then probably it's wrap-up time, I guess, unless there is one or two comments from anybody.
Could I just ask a quick question to the corneal experts, because I'm not an anti-segment specialist, but how do you differentiate the clinical picture, especially in the first case, from a post-adenoviral subepithelial punctate keratitis? Because to me, it seemed a little bit similar. So how do you differentiate the two things?
Well, the point is, when you have adenoviral lesion, you have evolution of the lesions. And you have evolution in the sense that it will regress, at least. But in the other, in the corneal dystrophy, it never comes in different way. So that's a first point important. And also, when you have the OCT, you have different access, and the regularity in adenoviral also is important. But it's sometimes not so easy.
That's right, because a lot of them, you know, which we have, they end up on a long-term course of topical steroids before you actually start seeing any evolution at all. It's just, you know, something to consider.
Okay.
In this case, you can use also cyclosporine.
Might I add something? I think history taking is also very important in differentiating between viral and viral conditions and dystrophies.
Yeah. Thank you so much.
I was just about to reinforce that, Nicolene. In one of your responses before we mentioned the OCT, is you went over it very briefly, but it's a very important point. You mentioned the fact that the patient was asymptomatic with these lesions, and I think it's a really important point when we're running through the ideas of infection or inflammation. The fact that you said you may not think that, or you may not take them to anesthesia because the patient was asymptomatic. I think it's a really important point to think of a dystrophy.
Thank you so much for that two lovely cases, Jamila, and thanks for the great discussion. It started from infection, inflammatory, finally landed up in dystrophy. I think it was a fantastic learning for all of us. But obviously, all of us around the world, I wish we had access to latest OCT and the genetics and everything. But nevertheless, I think it's a great learning experience. I just want to share quickly the results, and this will be sent to all of you. You can have an access to the PDF file of this. Both the case reports will be made with the panelists' opinion. I just wanted to share, and I also will make a quick announcement after that. Which part of the world you are from? We have 40% from Asia and 20% from Europe, and 10 each from North America, South America, and Middle East. And gender-wise, I think it's fantastic to see every time. I think female gender is beating here with 77%. It's amazing to see that. Webinar after webinar, we see the same trend. It's fantastic. How many webinars you have attended in the past? And this is almost 60% of the people have attended more than 15 webinars. That's great to know. With regards to the cases, the first Brown syndrome, one of the question was, how many percentage of horizontal deviation people see? 60% have not seen, 40% have seen the horizontal deviation with Brown syndrome. And the next question is, if yes to the previous question, what was the percentage? If I look at this percentage here, it varies from 2% to 50%. This is almost similar to the literature. 2% to 50% have horizontal deviation. The next question was, do you advise MRI in children with congenital Brown syndrome? I can see that 72% say no, but 28% go for MRI. And next is very, very interesting. If you advise MRI, that 20% of the people answered, what is the finding, most common finding on MRI? I can only see two things, pulley displacement and thick tendon and thin tendon. So that's again kind of what we really discussed in the webinar. And coming to the next question, what is the surgery of choice? Again, it's interesting. 31% will go for tenotomy, 14% will go for tenectomy, 27% each go for either suture spacer or other technique. And still 12% of them go for silicone band spacer. And have you ever done inferior rectus recession in Brown syndrome? 88% said no. Now I can see there is a jump. 15% have done inferior rectus recession in Brown syndrome. About the second case, clinical disorders caused by mutations in the same genes are best described. 30%, 40% say genetic disorders and 40% say allelic disorders. About the sclerotic scatter, how do you perform that? That question, 90% say that using the slit lamp and dissociating the column of light from the point of focus. That's the answer majority of them gave. The next question is, the majority of the corneal dystrophies in children are misdiagnosed on initial presentation unless there is a family history. Do you agree or not? 85% agree, 15% don't agree with that. And the next question, I think this is the last question. Have you seen corneal dystrophies in children under 16 years of age? Here, 70% seen less than 10 in their career. And close to, 8% each have never seen or seen 10, more than 10, but less than 30. And just 6% have seen more than 30 in their career. That's very interesting. And the final feedback was, what was the best part of this webinar? They liked, top one was the case, the discussion. Second one was the case presentation and the documentation. And the third one was very interesting, people from many, many countries. These are the top three things, what they have to say. I just have a few slides to show about the announcement. With that, we will stop our webinar. Just give me a second before I share that. We are going to have another webinar in the next week. It's on 10 pearls, clinical pearls on diseases in pediatric ophthalmology and strabismus. So I'm sharing my screen. Yeah. I really want to welcome everybody for this WSPOS Worldwide Connect 2020, which is going to happen on 26th September. It's almost condensing 3 days program into 1 day. It's a 24-hour program. You give us 1 day and we give you the world. I will also add that without experiencing the annoying jet lag. So please be there for this 24-hour program extending across the world. Everybody are welcome for this. Additionally, we please
Ramesh.
Yes, go ahead.
Ramesh, sorry, but I think what's special about it is the whole theme of that day will be the patient comes first. And every presentation will be based upon, every session will be based upon patient presentation, not diagnosis that the doctor makes, where we put the doctor first, but the patient comes first. So it's going to be the symptoms and the problems the patient presents with and what we do as a doctor. So as always, the World Society is keeping the patient first.
Thank you for that addition, David. It's fantastic. And we have categorized patient or children with different diseases. That's the 14 or 17 sessions we are going to have. In addition to that, we have a combined symposium of WSPOS and ESCRS on pediatric cataract and intraocular implants. And we have the 3 keynote lectures on 3rd October, as well as the best of the best papers and posters on the 3rd October. So once you register, all of you are eligible for all the programs, what is displayed here. And all of us, all of you are welcome to join our Facebook and also international listserv. This is the email ID of Dr. Granite, dgranite@ucsd.edu. And the WSPOS membership is free to all of us. Please join in and get all the updates. And the program will be there on YouTube as well. Today's program, if someone of you have missed some part of it, you can see there. Last but not the least, I just would like to thank you, all viewers across the world, the continuing support and the enthusiasm, the support and the interest to learn and share is fantastic. That's why we could reach this 18 webinar, and we are still going. And next week we'll have a very, very interesting webinar as well. I really want to thank both Gaura and Jamila, who did a fantastic case presentation. Both the cases were very interesting and educative. I want to thank the 4 great panelists from across the world we had. Thank you, David. Thank you, Dominic. Thank you, Nicolin, and thank you, Saurabh. And also, as usual, Kim, you've been fantastic. Thank you for your support as a co-moderator. Entire team are doing a fantastic job meeting after meeting. Thank you to the entire team. I really want to thank our WSPOS admin team, Emma, Dara, and Akhila, for constantly working on this and making it successful week after week. Thank you so much, everyone. Have a good afternoon, evening, or good night. And see you next week. We all will be joining for the WSPOS Connect meeting as well. Thank you, everyone. Bye for now.
Bye. Take care.
Bye-bye. Thank you, everyone.
Bye. Thank you.
Thank you, everyone. Bye.